Welcome to the Orthodontics in Summary podcast, where Farooq brings you the key points and understanding of orthodontic webinars, conferences, and papers in a concise podcast with your host, Farooq Ahmed.
Hi guys, welcome to the episode. Today we're having a look at the lecture entitled Vertical Control with TADS, Etiology and Treatment Modalities of Anterior Openbite and Relapse. This is by Jay Park and it's part one, as it's quite an in-depth lecture. I want to make sure we get all the content across. So I'm a fan of Jay Park. He's written a textbook on TADS and it's really helped me understand how TADS work and how we can apply their mechanics. So part one is going to look at soft tissue etiology and also the use of TADS for posterior intrusion and a little bit about anterior extrusion as well. So to start off with, Jay described the theories of soft tissue etiology for anterior open bites. There were two opposing ideas. The first was put forward by Subtelny in 1965, and that was that tongue thrust. And the classic idea was that it's a persistent visceral swallowing pattern which resulted in the anterior teeth presenting as an anterior open bite. The second idea came from Proffit later on in 1993, where he said, no, actually, it's not to do with the action of the tongue, it's to do with the resting position of the tongue being anterior, and that's what caused the anterior open bite. Now, this theory has then been refined, and it's pretty much Proffit's idea that's been taken forward. It's the resting position being anterior of the tongue that sits in between the teeth for hours of the day, impedes the eruption of the anterior teeth, and maintains the anterior open bite. And the treatment for this is twofold, depending on where vertically this tongue is positioned in the anterior segment. So if it's high, a palatal crib is indicated behind the upper incisors. If the anterior tongue is low, then tongue spurs. He referenced Farooq R.Juestus' paper from 2011, and I've covered that paper as well as a lecture of hers before, and I've been fortunate to interview her, so please do check that out in the previous podcast. So he went on to talk about the options for dental correction for an anterior open bite, and there are two main categories: posterior intrusion or anterior extrusion. Now he gave the two indications. So for posterior intrusion, we're really looking at increased low anterior face heights, excessive posterior gingival show, and a mild skeletal discrepancy vertically. For extrusion anterior teeth, we're really looking at normal anterior face height with excessive gingival display anteriorly. So he started off by describing, well, posterior intrusion can be achieved with using bite props as a bite plane effect posteriorly. So this is by placing 2 to 3 millimeters of composite on the posterior teeth on the palatal cusps. Now there's a trial that was carried out by Hernandez in 2017 that showed that actually we achieve about 1.5 millimeters of posterior intrusion over 17 months through this technique. Now, Jay developed that further to incorporate TADS into the process. So how did he do that? Well, he had an RME bonded design. He placed TADS in the dental-alveolar region palatally between the upper 5s and the upper 6s. He then had power chain running from the TAD on the palatal aspect over the occlusal surface, including the RME, going to a buccal hook on the RME, and this applied an intrusive vector of force. Jay also spoke about his other method of using TADS for posterior intrusion. Now, this involved using a modified TPA. So we've still got bands on our 6s, a classic U-loop. This time we've got hooks placed on the TPA. Now the TADS are positioned in a similar way. Posterior palatal segment, either between the 6s and the 7s or between the 5s and 6s. And that allowed him to apply elastic from the hooks to those posterior teeth. Now Jay did develop the argument and suggested, well, there's two ways. You can put it between the 5s and 6s posteriorly or between the 6s and 7s. He mentioned that it's easier to do it clinically between the 5s and 6s. However, when TADS are placed here, the intrusion vector is going to both the 6s and the 7s, and it causes mesial tipping off the teeth. He gave a really simple solution to it by putting a bend on the 7s to intrude them. Ideally, positioning the TAD between the 6s and 7s works better. There's less tipping forces, but it's a narrower distance in between the roots. The interradicular space is smaller, so we've got to bear that in mind when it comes to positioning. Now, what I liked about Jay's lecture, he also spoke about the negative effects of carrying out these mechanics. And as we intrude from the palatal aspect, it can leave the buccal cusp still hanging down. So how did he prevent this? Well, he gave a suggestion that if we use a quad helix to begin with, we can flare out to the buccal cusp and then carry out the intrusion in a two-stage approach, not too dissimilar to how we use a quad helix. We have initial tipping that takes place and then bodily movement for the expansion side. So using a quad helix initially to flare out to the buccal cusp, then palatal intrusion taking place means that we get that bodily intrusion taking place. He described the amount of force required for intrusion as being 300 grams per side. That's it for this episode. Please stay tuned for the next episode, which will be part 2, where we'll spend longer looking at the evidence associated with using TADS for posterior intrusion, looking at aligners, and also orthognathic surgery for these complex malocclusions of anterior open bites. I hope you guys have enjoyed this episode. There will be some notes that summarise a summary of this lecture that are in the description, and please do subscribe if you've enjoyed the episode.